Hello and welcome. Welcome to Heart, Navigating Lipedema Together with me, Catherine Sayo, and Lisa Dore, who is not with us today. But I have a wonderful surprise. Um, I have with us today a special guest, Dr. Matthew Carmody. He is a internist and associate professor at Harvard Medical School and has been involved with lipedema and with really the exploration and the discovery of all the different aspects over the past, got to be close to 20 years. So I'm going to bring him up and we'll hear from him. Hi, Dr. Carmody.
Hi there.
Thank
Um,
you for joining at the last minute.
sure.
Wonderful. Um, can you share a little bit about you and your background and how you got interested in lipedema and where that's taken you?
So I'm going to give you some things about myself. So that my career, and I am now retired from that career, but still active in terms of obesity and lipedema. Um, my career was actually in internal medicine. So I saw and had a patient panel. I was there on the front lines and I, took care of a large number of patients. In addition to that, I ran the um, intern resident training program at Mount Auburn Hospital under the auspices of Harvard Medical School, and reached the associate professor level at Harvard Medical School. I also did research during that time. And it had to do with how systems work. And the system that we were working on is how offices work. And we, published in that area. It was a cross Harvard study of how offices may work. And some of the principles that we elaborated at that time, um, one of the first things that we decided within 6 months of starting that trial was that we needed to have patients sitting with us, which is very obvious, it seems, to you all. But to us, it was like an eye opener because anything that we designed or thought needed to be checked out and reviewed by patients, or even designed by patients would be better. And so um, in my career, I became very fond of the fact that if I made a relationship with the patient that actually held them as being so important to the thinking of their case, then I always got a better result. And so I met this person who is also on the screen with me as a patient. And
That would be me.
yeah, um, she was actually having a weight increase that did not follow her pattern at all, in the sense that she was very able to control her weight and knew how to respond in actually a very scientific way to her weight gains and losses and how to modulate. And suddenly in her 60s, 50s, that really changed. That is, she started to get new weight. Um, and I would understand that it's in different areas of the body than was previously. I understand that now. I didn't realize it then. Um, and that it was not responsive to the usual measures that she used, which she actually it was diet and exercise and a lot of thinking about food and how food made her feel energetically, and also how it played with weight. And so she had been quite successful, reaching a very healthy weight level with that. And all of a sudden that failed. We we took a large number of interviews with specialists across the Harvard system, so to MGH and to Brigham and Women's and to Beth Israel Deaconess, and really tried to understand what was going on with her weight. So one thing that I learned from that journey was you have to have faith in the truth of your patient. If the patient, so that as a physician, to work seriously with someone and to work in collaboration, you have to actually think that that patient is as brilliant as you are. And the reason they're more brilliant than you are is that they live in the environment that we're talking about. They live in their own bodies. So I don't live in other. I only live in my body, and somebody is so that you, as persons in your own body, are an expert on that body, and you should be quite insistent, as Catherine was, about like knowing my body and how to take care of it, and the fact that it's not doing what it did in the past. But to make the rest of the story short, I would actually credit Catherine with going overseas and finally getting a diagnosis of lipedema, because nobody was able to diagnose her, that we had in the Boston area at that time. So she went over to what's called the Foldy Clinic, and actually was diagnosed at one of the premier clinics in Germany for lipedema disease. They're fantastic on lymphatics in general, and on deep research with lots of findings coming out of the clinic, and highly respected in the world, and also learned from in the world. So um, I think that so that's kind of my journey, and I think the the things that I've learned from that journey is that the local expert is the person who has the disease, and that the communication about what that body is doing needs to be clear and clean and well respected, and to be very careful about what you then do for that body. Things that make sense to you and when tried actually work for you. So anytime Catherine would try something, we would sort of understand what the baseline of her current status was, and also what she was trying to do and the expected result. So it's kind of a very scientific thing. It's not trying to be overly smart about it, but actually being aware and calculating and taking notes about things, and reporting odd things that are happening. Why did her fat become painful? In her previous history, that there might have been pain from joint discomfort, etc. But this had a new level of pain in it, and really quite unexplained and quite intense. So that's one of the signatures of lipedema. So I'm going to just pause here and ask for what direction you want me to go in next.
Well, let me say a couple of things because that was wonderful hearing you give that. I don't think I've ever heard you so succinctly talk about the process. Um, and what was so amazing is that Dr. Carmody actually believed me as I was, which is what he said. And he was that way with all of his patients. Um, but really being able to partner with, so that often questions that I would bring would be met with Dr. Carmody's knowledge. Obviously, a great deal more knowledge than I had about the body and how it works and what was going on. And even though there were periods of unclarity because we didn't know what was going on, there was a process in order to come to that. So I think, if we may, we are in the process of writing a book on lipedema, um, with a number of experts worldwide. I think there's 25 of us. And Dr. Roxon from Stanford Medical Center, Dr. Leslyn Keith, who works with us, and myself are the editors. Dr. Carmody's writing 2 chapters of the book. And when we were talking about this, you were mentioning to me the update of the German guidelines. So, as Dr. Carmody mentioned, Germany is way ahead, really, of anybody in terms of understanding of the lymphatic system. The Foldies have a clinic. There's a number of other clinics in the um, Vader is another clinic there. And we, meaning the US, has undermined or neglected is the better word, the lymphatic system. And so there's so many complexities. So, if you could, Dr. Carmody, maybe give a brief overview of the German guidelines. I know that's difficult, but even just a sense of it, because what they just published recently is an updated version. And then perhaps if we could discuss some of the updates, like what else, what do we know now about lipedema that's grown even in the past 10 years with more research and more exploration?
I think that I need to refer, and probably everybody has access to the paper that we did publish about how to make the diagnosis, and you have probably presented it in this.
Yes.
Okay.
And the
So,
paper that we wrote is case definition.
so the reason that that's important is that there is no blood test, nor is there any um, test that is a definitive diagnosis for lipedema. So that and people have finally come to terms with this and realize that we are not there yet. And although in 1940 in the United States and also in Germany, there was an attempt at defining what lipedema was. It was not acted on by a lot of people, but it actually came very close to what we understand today, and to which there have been additions. So I'm going to just say what lipedema is, and then I'm going to um, then tell you what the guidelines are saying to us. So based on our what lipedema is it's a problem with fat, and I'm going to tell you what that problem is, but it's a problem with a particular location of fat. So the fat that we are talking about, and for years I used to look at patients and say that if they had a fat or adipose tissue in their arms and their chest and their abdomen and their legs, I really just called that's obesity. That there is an accumulation of excess fat, and we used weight as the defining measure of what uh, if the weight is above this and at this height, of a person, then this person has excess weight or has too much weight. And you're well familiar, with that definition. But that this definition is different. It does not have to do with weight, um, but what it has to do with is a particular location of fat that is increasing in size. So the adipose tissue is increasing in size. And that area is, and I'm sorry if I'm boring you because you may well know all of this, but that those areas are in the hips, buttocks, and especially the lower legs, as well as possibly the arms. So those are the areas that are where the fatty tissue actually becomes large and disproportionately large. Like the chest and the abdomen are not necessarily increasing in size, and in fact do not increase in size due to lipedema. So lipedema is really only from the shoulders down the arms, from below the waist to the buttocks, hips, and legs. So that's its location. So we're really talking about a very special disease that is located in the areas that I just outlined. And so we say that it's not in the chest, it's not in the hands, it's not in the feet, it's not in the neck, it's not in the abdomen. There's some controversy about lower abdomen, maybe an area that people want to discuss a little bit about whether that can be part of the disease. But from the waist down, that is what we're talking about as far as the fat mass. And the second thing that we're talking about is that the fat mass must be painful or uncomfortable or heavy or feeling congested, so that it has to be in those locations, and in those locations the fatty tissue feels that heaviness, that pain. It can be just heaviness, discomfort, constantly trying to get comfortable with it and not able to get comfortable with it. So the basically the German guidelines, what they insist on is they insist on the two things that I just said to you. This is where the disease is occurring: arms, legs, hips, thighs, buttocks. And this is what the disease, that it must be uncomfortable or painful. So those are the two aspects that are really insisted on. Um, there are other criteria, that come along that I don't know that we want to jump into at this point, but there are other things, that help us to make the diagnosis, and those are. Go ahead.
We have about 7 minutes, just to let you know.
Okay. So what the guidelines then say is like, well, what works? If once you've defined it, what works and why are you why are you doing this? So the feel the things that work are a application of compression, and so that's done by manual lymphatic drainage or the wearing of special clothing that actually causes the fat to decongest. Because the problem is there is a lot of congestion in the tissue, and it's believed that that is giving rise to poor circulation in the tissue and causing the tissue to be painful. So the objective is to actually, pain is reflecting that the tissue is inflamed. So you want to take measures that allow inflammation to decrease. So those measures might be a dietary intervention of low sugar diet, very low carbohydrate diet, or a high fat diet with moderated sugar. So those two things seem to start shutting off the inflammation. The decongestion is done usually because you're not an expert at decongestion. You can wear a compression garment, but it is always best to have it fit well to you so that it actually does its job. It's also there. You can use there's a lot of pressure uh, uh, garments that are available. There is what's called manual lymphatic drainage, which is done by a therapist, um, and is done on a regular basis. And the other thing that's extremely important is that your weight be as good and stable as it can be. That's the first. Um, and that you actually exercise. Uh, and we're talking about uh, being mobile, walking around. So we're talking about the fact that that improves the lipedema tissue, is to have exercise. And the exercise is very hard to do because of the way that the fat is laid down in the hips and the legs, make it very difficult to get up and walk at any distance. And so it is critical, that you do walk because you are taking advantages of your internal systems that push fluid out of your legs, out of your arms, if you're about walking. So I think one of the magic things that you can do if you think that you have the first of all, you should be diagnosed by somebody that knows how to diagnose. But the second thing is that a walking program every day is just the returns on it are going to be stupendous. So something to be done, and then to engage your physicians for diagnosis, and then referral to people that are experts at moving fluid from your body.
So, one of the things that I want to interject is there are some of us that find it very difficult to even walk around the block. I have found that as I've aged and my lipedema has aged, it's very difficult. But what is less difficult, in fact, isn't difficult at all, is being able to walk in the pool. So I find that walking in water will achieve what Dr. Carmody is referring to because it keeps the fluid moving, which is what the goal is, and the decompression process in process. Um, we have so much more that we need to talk about, but this is our weekly podcast. It's enough to sort of dip our toes in the water, so to speak. I think we should have a longer webinar about this, Dr. Carmody.
Okay.
Let's plan on something and invite people in the community. Um, yeah, Catherine is saying, someone is saying, garments are expensive. Garments are now covered by insurance. So you should check with your insurance company. The lipedema advocacy, um, they um, they passed, after 10 years of lobbying, they passed a law that went into effect in this past January. So we are entitled to, I think it's 3 garments every 6 months, but you need to have a diagnosis of lymphedema as well as lipedema. Um, Sherry says this was fantastic. Many thanks to both of us. You're welcome. I'm so grateful that Dr. Carmody could come join us this morning. And so, for those of you who are watching the replay, welcome. I'm so glad you're here. We are going to be scheduling a webinar because this is so fabulous. And there's so much more to understand about the German guidelines and lipedema and all the aspects of lipedema. So we will do that. So thank you, Dr. Carmody.
All right.
I appreciate it. And have a wonderful day, everyone. Morning, afternoon, evening, wherever you are in the world. And thank you so much for being here and working with us, navigating lipedema together.